Thank you for joining part 2 of our webinar series on how to prepare for HR1 coverage disruptions. Our host today, Joseph Rivera, is back. He is our senior Medicaid consultant for Alcar Health, and he's going to walk us through practical steps on setting up a robust internal and external campaign to ensure patients are connected, engaged, and educated. So I'll go ahead and turn it over to Joe to get us started.
Hey, thank you so much, Joanna. I appreciate that. And it is really my privilege to be here today to talk to this distinguished group who are on the call today. For those of you who were attended our part 1 of our webinar series, welcome back. If you didn't, if this is the first time you're joining us, I'll just share a little bit about myself. I come from the health center world. I was with a community health center in Southern Colorado for about 27 years. 20 of that was in outreach and enrollment. I led a team to implement numerous expansions and retention projects for Medicaid and other programs while I was there. And then in 2020, I started consulting on my own practice. And since 2021, I have had the distinct privilege of working with Alex, partnering with Alex and Alcar Health on numerous projects that promote enrollment in Medicaid, the Medicaid program. So that's really my background. I've worked with some primary care associations and NAC and several health centers. But this is really what I like to do. I love doing a little bit about myself, and just so you know that this is really professionally, this is where my heart is with health centers and with this particular work. And so it's a real privilege to be here with you. For those of you who were not with us in our first series or our first part back in September, just a quick recap of what we talked about on that day. Really, what it came right down to was starting with a data analysis, looking at your patient, your self-pay and Medicaid patient population. Analyzing who you have as self-pay, how many children, how many adults, and then really looking at their household size and income to determine, are they potentially eligible for a Medicaid program. And many health centers who've done this have found been very surprised by what they found from this kind of an analysis. Perhaps thousands of their own patients who are potentially eligible for Medicaid. Perhaps even hundreds of children who may be eligible for the Medicaid program. We know that there are situations where individuals have no choice whatsoever. They're going to be on sliding scale because of their citizenship or residency status. But outside of that, if they meet the household size and income requirements, they could be potentially eligible for Medicaid. And as we know, Medicaid is a bread and butter of the health center's revenue. So obtaining and retaining Medicaid members is extremely important for a community health center. But that's where it starts, is with data analysis, knowing who your patients are. And as I mentioned, health centers that have done this have been quite surprised by what the findings are in this. And so that's basically what we talked about in our part 1. Today, though, we are going to really focus on what to do with that data. You've identified your patient population that are potentially eligible. What steps do you take from that point on? And so I'm going to share my screen now, and we're going to go into this presentation. And so if you'll please bear with me. I will share that. And we'll go into slideshow. Here we go. All right. Okay, so what we're going to learn today, we're going to talk about best practices in implementing an in-reach campaign. So once you have from your reporting or your data analysis a list of patients who are potentially eligible for Medicaid, then you will want to reach out to them. Well, how do you do that? What's the best way to do that? We're going to see how using multi-channel communications to reach them is really important. What channels are better than others? Every health center is different, though, and so you may already, in fact, be employing these methods to reach these ones. Also tracking and reporting tools for in-reach campaigns. And so once you start a campaign like this, you're going to want to track. You're going to want to see how that's working. Is it, where can you improve what's working, what's not working, and then reporting on your activity. And then best practices in creating and supporting an enrollment team, be that on-site, in-house, outsourced or virtual, or even a hybrid model. We're going to be talking about some different models on staffing or workforce for outreach enrollment. And then this is going to be a message you'll hear from me throughout this presentation, is just how important it is for everyone at the health center to take responsibility for mitigating coverage losses, and how that could look by involving others outside an outreach and enrollment team. As we talked about in part one, we're going to just discuss this real quick too, why it's important to act now. Acting now to obtain and retain Medicaid members will prop up your revenue in advance of the HR1 provisions that are coming. As we know, those provisions that are going to impact health centers profoundly are going to be work requirements and twice yearly redeterminations. On top of that, we talked a little bit about in part one, the provider tax or provider contributions, where federal matches are used at the state level. That has been a revenue boost for health centers in some states, where that is going to change also. But there's going to be a lot of threats and opportunities for health centers to respond to HR1. Recognizing it's a year away. A year is going to come by really fast. States are going to need to be ready to implement this by October of 2026. And then as of January 2027, that's when the implementation goes into effect. And so there are going to be unavoidable coverage losses at that point. So right now is the time to put into place these strategies, data analysis, putting together an in-reach campaign and workforce to do that, and enroll really every single person that is potentially eligible at your health center, your patients. And so again, that's going to be so important. That cushion is going to be needed because of those revenue losses coming in 2027. But it also puts you in a good place too, to have your pieces, your chess pieces in place, as it were. So when those provisions do go into effect, you'll be in a good position to help your patients. Just think about this from the patient's perspective. As they start receiving notices on complying with work requirements, we know from experience that many of those notices are confusing. The patients don't know what to do with them. They don't understand them. They're going to need help. They're going to need help to comply with that. Perhaps a great portion of your population, the younger ones or such, may have no problem with that, to seamlessly move through that process. But there will be a segment of your population that will not. They're going to need help. That's not even to mention the twice yearly redeterminations. Our experience in some states, or where the redetermination process, as it is right now, takes months. The patient receives a notice that they're up for redetermination. This is the documentation they need to submit. They submit that documentation. That is, if they pay attention to it. They submit that documentation, and then it may take 45, 60, even 90 days before the Medicaid office actually processes that application. Then they get approved. 2 months later, they're getting another notice for their next redetermination. So that's when redeterminations are happening twice a year. Now, can you imagine how confusing that could be for them? So having in place, working on this now, to have that team in place to not only reach and enroll those who are currently eligible for Medicaid, but having them in place to be able to provide that assistance when these provisions all roll out. And obviously, your patients are going to need help. You're in the best position to do that, to provide that help to them, that messaging and education to them, so that they can continue to access the care that they need. Before we go on to this next slide, let's have a poll. We'd like to release a poll here. Actually, I'm sorry, Natasha, let's go ahead and just talk about this. Well, let's see, let's make sure we got this right. Oh, no, I'm sorry. Yes, let's release this poll. We'd like to just learn a little bit about what your experience is at your health center, how you're reaching those who are Medicaid eligible. The question is, what methods are you employing to reach and enroll Medicaid eligible patients? And is it multi-channel communications, data analysis to identify Medicaid eligibles, front desk and intake workflows to identify them? Are you still developing a strategy? If you are, that's great. Is it something else that you're doing to reach this population, or if you're not doing anything at the moment? So please take just a few seconds to answer this poll. There are no wrong questions. And it's also nobody's going to see your results or your selection, but we certainly love to learn what you are doing. So let's give that a few seconds to do that. So Natasha, when you think that we've got most who responded, go ahead and release it.
Okay, I'm going to go ahead and end the poll and share the results.
Okay, great. Oh, wow. All right, this is nice. So you're utilizing multi-channel communications and messaging. That's very important. We're going to talk a little bit about that today. Data analysis, 38%, or using data analysis to identify those who are eligible, and then involving front desk and intake workflows to identify them. That's terrific. And then, of course, 23% or 25% are still developing a strategy. And really, we hope that today's webinar will help you even pick up 1 or 2 points that you can use to improve that strategy or to be part of your strategy. If so, then certainly we want to support that. So let's talk about what InReach is. Let me get to the right slide. And okay, I think we had the same problem the last time. I'm going to stop sharing and then go back in. I apologize for this. We're going to give that another shot. See if we can get back to the correct slide. Yeah, Natasha, that is, there we go. Thank you. All right. So what is InReach? InReach is something that you are more than likely already doing. This is an activity that reaches a current population for any reason. If you're involved in population management functions at your health center, such as reaching out to those with chronic disease, diabetes, helping individuals to schedule their annual wellness exams, you're doing InReach. You're running the patient data, the reports, you're looking at who needs to be reached out to, and you're doing it either by phone calls, text messaging, things like that. Medicaid enrollment InReach is basically the same. You're using patient data to identify new and renewing members at your health center who are on Medicaid. So that's really the first step, by using that data and then developing a message to promote the activity, what, why, when, and how to get that assistance, why they need to get the assistance, what they need to do, how they can apply or renew their coverage. But just having that messaging is really important as an important next step. And then multi-channel communication. So how do you get that message across? That's through text, emails, signage, face-to-face at your health center. What we found at Alcar Health is that text messaging is very successful. There's a segment of your population who may ignore phone calls, but they do respond to text messaging. And really all that involves is getting that text and getting the message across on what they need to do next, what steps they need to take to get that assistance to be enrolled in Medicaid. But these different channels, and it really depends on your patient population and your health center, what that preferred method is. It could be email. It could even be letter. There's some health centers that are still using mail. They're in a position to get updated mailing addresses, even though that does change a lot these days. But those mailing addresses, you sending a letter and getting that response from that letter, I think is for some health centers has been successful for them also. But I think text message in this day and age is really one of the better ways to reach them and to get a response. Also, and then at that point, provide assistance to those who are identified and reached and helping them to enroll. And again, as part of that messaging, showing them how to do that, what they need to do, who they need to contact at the health center to get that assistance. And then, of course, tracking and measuring your activity and outcomes. If you have an in-house enrollment team, if this is what you're doing right now, then you're no doubt using your EHR or some other database to track who you're assisting, what the outcomes are, how many applications are being completed and submitted, how many approvals. Those are important data points to know how many of those are actually being approved for Medicaid. And then and any other data you want to track to show the success of that work. And then we're going to talk a little bit more about this later, but having handwritten policies to promote accountability. And we know that HRSA requires specific types of policies and procedures, and this may not be something that you're doing, and even if it's not required in per se, even having something in writing that everybody is aware of and that has a uniform processes and procedures that they can all follow, and they'll be responsible for doing that is a good thing to have also. What I've noticed at health centers is that they may have numerous folks who are involved in in-reach or in enrollment, but they're just not doing it the same way. It's not uniform in how they're doing that, and it makes it a little disjointed, and tracking and reporting also, they're not doing it the same way. So it's just an extra layer of efficiency that you can add to your in-reach campaign. A successful in-reach involves everyone. I've already mentioned this. It goes beyond your outreach enrollment team. That means involving front desk, your call center, intake, providers, case managers, and others, even in billing. Let's just talk about a couple of these, how this might look with providers. If when providers are providing care to their patients and they have to make a referral for services outside the health center, like perhaps imaging or a specialist, they may very well be looking at or asking about, well, what insurance do you have? I see this is your insurance. Okay, we can move forward with this. But if they see that the patient is self-pay, they have no coverage at all, that is a good opportunity for even a provider or nurse to say, okay, we have somebody that you can talk to help you to apply for Medicaid or some other program to help them cover the cost of those services. But sliding scale is only going to cover what's inside your walls for the most part. And but outside of that, they're going to need that additional help. So providers, billing is another example. Your billers or your patient representatives who review reports on those who are self-pay, and if somebody's responsible for collecting unpaid balances if they see that somebody has had a service and they don't have sliding scale, they don't have any kind of coverage. As they reach out to them, this is again messaging that can be used as part of your in-reach campaign to say, hey, look, see you have no coverage, no insurance for your last visit. We have somebody who can help you to apply for Medicaid or another program to help cover the cost of this service. So everybody can be involved in terms of those are patient-facing, operational, those in operations, and even some clinical. I mentioned here case managers and care coordinators who are in a very good position, the social workers, CHWs, and your health center are very useful positions to provide that messaging to them on how to get access to this kind of coverage and assistance. Okay, well, this is basically it on InReach. I mean, these are practices that we've seen really do work, and we recommend these employing these types of practices at your health center. Before we move on to talking about workforce, are there any questions? Please, I didn't mention this, but if you have questions and that you'd like to get answered, please put them in the chat. If there are any questions related to this, we can answer them now before we move on.
Joe, I don't mind jumping in with a question. I was going to save mine for later, but I think this is a good point just to ask one question as it relates to building and establishing an InReach program. What are some best practices maybe we can share at this point in terms of messaging and just leveraging the trust that patients have with the frontline staff already and the providers? Are there any other best practices that you'd want to call out here?
No, I think those are extremely important. So thank you for that question. Those are extremely important, that trusted relationship that they already have with those at the front desk and other members of the operations and medical teams. And certainly getting that message across to those channels is really important. I would say, though, that in before even starting this campaign, an InReach campaign, you really should have the buy-in from very key members at the health center that are going to support this. And I'm talking about the COO level, at the executive level, the chief information officer, because they may be involved in the reporting and data analysis in providing that data to those who will be giving that message or reaching out to these ones in the health center that are potentially eligible. So I think there are key positions at the health center, in addition to those who are going to be actually doing the work, obviously, that really need that full support behind a project like this.
Absolutely. It's key to have all of the buy-in and cross teams aware and ready to deploy and to take action. So,
Yeah.
All right, well, I'll let you get back to the workforce portion.
Okay, terrific. Thank you. All right, before we do that, we're going to have another poll. And we're going to talk, as we talk about a workforce. So you've identified who you need to reach out to, you're reaching out. Well, who's going to do this work? Who's going to help people to enroll, to understand what they need to do and to enroll? And so this next polling question, again, to just kind of gauge your experience. What is your staffing model or workforce model for outreach and enrollment right now? Is it an in-house enrollment team? Is that what you're utilizing? Are you utilizing a virtual or outsourced enrollment? Staffing, are you developing a staffing strategy at this point? Are you utilizing CHWs? Does that kind of rise to the top of what you're doing for outreach and enrollment? Are you using any AI tools to perform enrollment too? So we'd like to learn a little bit about what you're doing. So we'll give you just a few seconds to answer these questions, and then Natasha will end the poll and we'll take a look at the results.
I'll give it about 20 more seconds, Joe.
Okay, great.
Okay, I'm going to go ahead and end the poll.
All right. Well, so it looks like we have 100% are utilizing an in-house enrollment team. That's very good to know. It's very good to know. We're going to talk about that. We're going to talk about some other staffing models or workforce models that some health centers are using also. So thank you for participating. We appreciate that very much. We'll go ahead and close it now and move on. All right. Let's see here. See if we can advance this. It's going to let us advance after releasing that poll, and it does not look like it's going to let us do that. So I will stop sharing and then reshare screen. Looks like we're having technical difficulties. Okay, I know what I need to do. I'm sorry, everyone, about this. We had the same thing last time and thought we had it. We really thought we had it beat. So okay. Let's see if we go back to slideshow if it'll allow us to do that. Ah, here we go. All right, a workforce that meets the demand. And again, let's just talk about what that demand is. As we've spoken about earlier, that demand is going to be those who are currently potentially eligible for Medicaid, whom you identify and need to be reached to enroll in Medicaid. And then, of course, looking ahead, that demand is going to be just as great when HR1 provisions are implemented and your patients are going to need help to work through compliance issues with workforce requirements and twice yearly redetermination. So having a workforce to meet that demand would mean leveraging patient data to right size an enrollment team. And what I mean by that is if you've identified, 1,000 patients, for instance, that are potentially eligible, and you only have one enrollment specialist on staff, is that going to be enough? If you look at the ROI, which we'll talk about later, would it be cost effective to add another one or two individuals to that team to meet that demand? So utilizing data to right size your enrollment team. Also leveraging that data to identify and reach those Medicaid, those who are Medicaid eligible. So you want that workforce to do that. Those who are specifically tasked with calling, texting, and scheduling and assisting those who are potentially eligible for Medicaid. And then, of course, they're going to need to be trained to screen and assist patients to obtain or renew Medicaid coverage. And I wanted to just bring out a point here. Now, if this is your model at your health center, great. There's no wrong way of doing this, in my opinion. But I think a best practice is to not have just application completers or assisters. What I mean by that is, in some states and counties, as far as the DHS office is concerned, all you have to do is just help them complete an application. That's it. You don't have to know whether or not they're potentially eligible. You don't have to know anything about Medicaid. Just help them fill out the application. And no doubt there are agencies that do that. But really a better way of doing that is training your team to understand how Medicaid works. How does Medicaid work? What does it mean? How do you determine what a household size is and what is countable income? What happens after the application is submitted? How does that work? How do you educate the patients on these issues? But understand how Medicaid works is really in our opinion, the best way to do it, because you're not just application assisters. And what I've seen happen is that as an application completer, you do that. You spend all this time helping them to apply to complete the application, perhaps even submit documents, and they're not eligible. They were clearly not eligible to begin with. It could be a big waste of time and resources if they don't know how Medicaid works, what is involved in eligibility, what does the county or state look at when they determine eligibility. And so to me, that is best practice, is to just do that and not just have somebody helping to fill out applications, but really do understand how Medicaid works. Also, if your model is to have a frontline screener, in other words, the screener takes a look at this patient's household size and income, to the very best of their ability, they're able to determine that this person is potentially eligible, and then they send that patient, they hand that patient off to an enrollment specialist. Then that's a good model too. But they should be trained also on how Medicaid works. But if that's all they do is screen and perhaps even schedule appointments for the enrollment specialists, we've seen that it works very well. I think the point is, though, is that it's not, you don't have a passive a model where the patient comes in and they're seen to maybe put on sliding scale and that's it. It really goes no farther than that. But somebody who's really responsible for saying, okay, is this patient potentially eligible for another program? Let's get them in touch with somebody who can help them. So let's take a look at some models. Love that the poll we just released, because on-site is one of these models that works very well. Virtual enrollment teams, we're going to spend some time talking about that, and then a hybrid model, mixing the two, and then just a little bit of information on AI tools. So a virtual model, we'll talk about that first. A virtual outsource model, a virtual team would really serve as an appendage to the health center. What I mean by that is they're really no different in many ways than having an on-site or in-house enrollment team. These are just virtual, they're outsourced, but they are the enrollment arm of the health center. They're not just some shadowy entity, contacting your patients, but they really are well integrated into your health center enrollment functions. This group would utilize health center patient data and reporting. So this is reports that would come from the health center on who these patients are that need to be reached. And then work closely with the health center, just kind of related to that, on messaging and providing that data. I did want to just really stress this, that a best practice is having a liaison at the health center who works directly with that outsourced or virtual team to provide the data, messaging, feedback on how things are working, any feedback from the patients on what is working, what is not working, if any improvements need to be made. And then in turn, the virtual team provides the service and reaches out to and enrolls those patients who are potentially eligible. But having that back and forth, having that good connection with the health center is invaluable. That's what we recommend if you were to take on a virtual model in reaching and enrolling those patients. Using text message and phone. So that's really the primary way that a virtual team will reach these patients who are potentially eligible, by using text and phone contact. Our experience at Alcar is that this is very successful. Now, not everybody answers their phone, not everybody answers text, but we do have a good track record in reaching these patients, because the information, the phone and phone numbers, for instance, that's being updated at the health center, and that's being shared with the enrollment team, the virtual enrollment team. So they're utilizing those channels to reach these potentially eligible patients. And then of course they're providing that online virtual assistance to apply from Medicaid. In California, the Medi-Cal program, then this has been a really successful. The team has done very, very well in reaching and enrolling these ones in California. Medi-Cal really, the way that the state has the system set up, it really lends itself to getting that enrollment, that virtual assistance for these patients. And then another very important part of this, now this is also done at the, in the in-house enrollment team level. If you're doing this in-house, we do this also virtually, and that's the follow-up work. That is just as important, if not more important, than the enrollment itself, or the application assistance itself. Because once that application is released, it's sent to the county or to the state Medicaid office, then it's pretty much out of our hands, out of your hands. and it's up to the agency to determine eligibility. That may take some time. So that follow-up is really important. After 2 or 3 weeks of a submission, the agents or virtual team starts to follow up, calling the patient, asking, have you received any notices from the Medicaid office? Is there anything that you need to do that they're asking you to do that we can help you with? But basically, it's facilitating a seamless enrollment. They're able to, with HIPAA compliant tools, get that documentation from the patients and then forward that to the Medicaid office so that that application can be processed and completed. So those are just some examples of how that follow-up is done. And a virtual enrollment team should be doing that, just like an in-house enrollment team should be doing that. You don't want to just send the application off and then forget about it. We want to make sure that they are in fact being enrolled and approved for Medicaid. That takes time and it takes effort to do that, but it's extremely important to have that follow-up. Also, assisting and anchoring patients to the health center. The model we have in California is there are several there are health plans, but there's also the ability to anchor that patient, for that patient to select your health center as their PCP, as their provider, and that's going to help you with your per member per month and other numbers that you have with the state that you're in. But anchoring them, so that's also the role of that should be the role of an in-house, or excuse me, a virtual enrollment team. And then, of course, the report on activities and outcomes as needed by the health center. One thing that Alcar does is they report on a monthly basis data points such as the number of applications submitted, the number of approved applications over the last month, the number of denied or canceled applications that happened during that month. And so that gives that health center the data to see, okay, this is working for us. This is the potential revenue that we're getting from this work that this virtual enrollment team is doing. But that reporting and that back and forth feedback and engagement with the health center is really important. But obviously, this is data and information that a health center is going to want on a regular basis from that virtual enrollment team. And then just wanted to talk a little bit about the cost effectiveness of an outsourced team, the housing, training, salaries and benefits, the hiring, all of that is done by the contractor. That takes that completely out of the hands of the health center and puts that in the hands of the contractor, and they're responsible for all of that. Obviously, with a virtual enrollment team, there's not that additional cost of housing and housing that staff and other financial advantages to having an enrollment team, a virtual enrollment team. And let's talk about an in-house. An in-house is pretty much the same as a virtual, but with a few differences. They too will utilize patient data to identify uninsured. The health center, however, will be responsible for hiring and training that staff. Here's one best practice, and I've seen different models at different health centers, but this is one that I think is the best, and for a number of reasons. And that the health center hire an enrollment manager. Now, I'm not talking about a director that oversees numerous departments. I'm not talking about a member of the leadership team, because that's what I have seen. It's really hard. Directors and leadership have so many responsibilities, but enrollment manager will be responsible for training and supervising assisters or eligibility specialists, and also mentoring them, the day-to-day supervision, reporting that needs to be done on their team's activity to their director or to leadership. But that really takes that load off of directors and off of leadership and puts that in the hand of an enrollment manager. So enrollment managers really are not just supervisors. I mean, they are really take the bull by the horns, and they make outreach and enrollment in-house a success. That really is their responsibility and what their task is. So having an enrollment manager, I think, is really the best way to go if you're going to have an in-house enrollment team. In-house enrollment teams should be working closely with front desk, intake, billing, and clinical staff. We've already talked about that with InReach and messaging, but still, that's that back and forth engagement and communication that an in-house team should have with all of these departments to make sure that people are getting the help that they need to apply for Medicaid. And then, there's no getting around it. An in-house team has a direct impact on patient experience and the financial stability of a health center. Studies have been done on this by NAC and other organizations to show there is a direct correlation between the activity of an enrollment team and the financial stability of a health center. Perhaps you've already done this study yourself at your health center. If you have, hats off to you, because it does show that the impact that outreach and enrollment at your health center has on so many levels. I can't stress that enough. So many levels at the health center. The patient experience. Can you imagine? Patient comes in and they're hurting financially. They need to have medical services that they cannot pay for. And you have someone there to help them to get access to care, to cover the cost of that. Can you imagine the relief they're going to have? And when this is done in a compassionate way, that just raises their estimation of your health center that much more. And they're more likely to recommend your health center to other members of their family and friends. It helps you to grow your practice when you have that good patient experience. And obviously we see that too with front desk and other patient-facing departments at the health center. But an outreach enrollment does have a definite impact on that patient experience. They're also going to track and measure their activity and outcomes. Again, that's more than likely to be done through your EHR. If you have templates developed to do that, Alcar has helped in-house teams to develop those data points that they can report on a regular basis too. So, but it's extremely important to really measure the progress and success of the work that they're doing. I think we already talked about this too. The health center is going to be responsible for, with an in-house team, to hire, train, pay, salary and benefits, and house these teams. So if there's any con to having an enrollment team in-house, that is just a little bit extra cost in doing that, having them in-house to provide these services. But it's still, no doubt, extremely viable and important to have somebody who is doing this work trained to provide this assistance. Thought I might be missing something. Oh yeah, okay. So that's an in-house team. If those of you who are on the call today who have using in-house enrollment team, as you look at this, you're probably saying, yeah, I do this, we're doing this, and that's great. We love that you are doing that you have taken steps to provide an enrollment team, to support an enrollment team at your health center. So that's terrific. Now, if there's any of these that you're not employing and you think you could do that, you could start doing that, great. You might be doing things that are not listed here that are making your in-house enrollment team a success. We'd like to hear about that too, by the way. You can even put that in the chat. If there's something that's here that's not here that you're doing that is contributing to the success of your in-house enrollment team. Now, a hybrid is basically what it is, that's using an outsourced or virtual enrollment team to support and augment the activity of your in-house team. So as you start an InReach campaign, you're looking at your data and you see that there are way more patients that need to be contacted than your team can possibly contact, then that's, bringing in a virtual team to do that is a good way to get a hold of those patients. They can act as a contact center. In other words, reaching out, speaking to those ones, connecting them with your enrollment team, or even augmenting those enrollment services too, and helping out and supporting the enrollment team by doing some of that enrollment also virtually. So that's a good model. It works. Alcar Health has used this method of augmentation for quite some time, but that can also be applied to enrollment and InReach. Just a few other best practices. Some of these we've already talked about a little bit. Making InReach enrollment everybody's responsibility, and that starts with efficient workflows at the call center and front desk level. If that's where that first contact, that point of entry comes, either with the call center or front desk, and making sure that that pipeline to your enrollment specialist, either in-house or virtual, is there, and having those workflows in place so that they can do that. I want to talk a little bit now about sliding scale, because we really can't separate sliding scale from any other enrollment activities that you're doing at your health center. And again, sliding scale could be one of those points of entry where the patient goes to see somebody who does sliding scale because they need to see a provider. They need to access care. So having a robust and accountable sliding fee process is vital. Teaching those who, if your model is you have somebody who is doing sliding scale that is not in Medicaid enrollment, it's a separate position, then they should be trained to do accurate screening for Medicaid, even if it's just a very quick screening based on household size and income, and then not allowing that to just be a passive sliding scale. And so what I mean by that is we've seen where as data analysis is done, that there's adults and children who are on sliding scale who really were eligible for Medicaid, but that connection with enrollment was just never made. And so they stay on sliding scale for a full year. They might access care 2, 3, 4 times, if not more. And basically you as a health center have to cover that cost through uncompensated care. You collect, perhaps, maybe, if there's a co-payment, you may or may not collect that at the time of service or even later on. It really, the full weight of that encounter falls on the shoulders of the health center rather than on a payer source like Medicaid. As I already mentioned, there should be a meaningful referral workflow that is to connect with these virtual or in-house specialists. And this is another piece I think that would be really nice to have written, to have a written policy or written procedures, I should say, and whether as part of your sliding scale policies and procedures or separate, to show that everybody is responsible to follow this workflow or these processes to get that person to an eligibility specialist if it appears that they may be eligible for Medicaid, and that thus avoiding that passive enrollment on sliding scale. It really is going to impact the financial stability of your health center when you have those workflows and everybody is following them. And so again, having something in writing that everybody is responsible for and accountable for is really a good practice. I've seen some really successful models or in-house models where they're providing that assistance, but with their data analysis, seeing we're missing something, and that's really generally where it's at, where that referral from sliding scale to Medicaid just wasn't done. There may be various reasons for that, but even tracking those reasons, tracking that referral process is a good way to see what improvements you could make at your health center. Utilizing CHWs and other support staff to enroll patients. There's a lot of health centers and states that are utilizing CHWs to do this. In some states, Um, uh, CHWs can use, if not outreach enrollment, but other services as billable services, so that you get something back for even providing that work that CHWs are doing, yeah, along with outreach enrollment or an enrollment encounter. That patient might need other services. They might need help with housing, transportation, or other things that CHWs can provide that help with, and those services are billable. But more and more I'm seeing this where CHWs are being employed to help with Medicaid and even marketplace enrollment. And obviously, again, just tracking and measuring your activity and successes. Can't stress that enough, that you do that in-house or virtual, that there'll be some processes for really to be able to report on, this is what we did, this is what we're doing, and these are successes we're having, or this is what we need to improve, or this is working, but this is not working, but this is working, and that data will help you to see that. All right, our final slide here is just on the ROI. I mean, we can be honest here, hiring and paying for enrollment in-house or even virtual enrollment staff, it costs money. It may be money that you feel you do have, or you have a little bit of, or it's something that you really have to make some decisions on, and recognizing that health centers have many competing priorities. But we're just asking that outreach enrollment be one of those, because of the impact that it has on health centers' finances, their revenue, financial stability, and consider having an enrollment team in whatever fashion to provide these services. We provided just an example here of what a data analysis might show, and what would be the result of following that through with enrollment. We have two areas here, identifying new enrollees, and then those who are already on Medicaid who may need help to renew their coverage. So as an example, you did your data analysis, you were able to, in your findings, saw that there were 1,000 patients, children and adults, who were potentially eligible for a Medicaid program. And in your health center, as an example, your PPS rate is $200 per encounter. And on average, your patients are being seen 3 times a year. That's $600 per patient. And at 1,000 new enrollees, you're looking at $600,000 in new revenue that you did not have before. And that's the revenue potential for having these services, not only identifying who these are, but reaching out to them and helping them to enroll in a Medicaid program. Same thing with renewals. Perhaps you have 10 or 20,000 Medicaid patients that you have listed that are members, or that are receiving services at your health center, and you're able to assist just 2,500 of them to renew their coverage. We're using that same formula of $200 per encounter at 3 encounters a year. That's $1.5 million of retained income. And, if we learned anything from unwinding the Medicaid unwinding in the last couple of years, is that states have a long way to go in still have a long way to go in making it a seamless process. Your patients are going to need help with this. The number of procedural disenrollments, after all was said and done, was staggering in the United States. Some states had even higher percentages of procedural disenrollments because they did not comply with the requirements to redetermine. And so that's where an enrollment team comes in. This is going to be extremely important when HR1 provisions go into effect, twice yearly enrollments. So just looking at the potential, what an enrollment team can do for your health center in not only obtaining a new revenue, but retaining that revenue that you really need, that you desperately need in your health center. So just keep that in mind. The cost, Joanna, just before I go any further, how are we doing on time?
We have about 4 minutes left.
Okay.
So yeah, no,
Okay.
great information, Joe. Thank you so much. First and foremost, I do appreciate you bringing the human experience into the conversation, specifically with the correlation of having an enrollment team, having that person or persons that are really going to handhold the patients, because you're right, patient experience is vital and patients are going to be confused and need help. And conducting redeterminations 2 times a year just simply seems brutal. So thank you for calling that out. What I'd like to focus on is going back to the two different models that were shared, the hybrid model and the virtual model. For the hybrid model, obviously poll number one showed that most FQHCs do have an in-house outreach and enrollment team. And we know that to be true because we do work with a lot of FQHCs which do have outreach and enrollment teams. How would you advise a leader to approach the idea of bringing an outside partner to assist, augment, or simply train their staff, as you mentioned, really having a good understanding of Medicaid and how it works? How would you advise on an FQ leader on bringing in an outside partner that wouldn't really threaten or cause strife to their existing team?
No, great question. I love that. And it really comes down to data. And so if there are more patients than an in-house team can realistically reach out to, then bringing in a virtual model to help with that is going to be vital. Alcar Health has such good experience with that, and not only bringing in that virtual model, but even helping to train and work with health centers to even develop and support their in-house teams. But the reason there would be no threat there to that in-house team is because we're all on the same team. If we're really looking at health centers fighting for their financial survival, and I think this is going to be coming to the fore even more as we get closer to the implementation of HR1. And keeping the doors open and continuing to provide the great care that they're doing for patients now.
Thank you, Joe. And I love that you said we're all on the same team, because it is true. For the virtual model in our last minute here, I just want to mention virtual does not mean that they are bots. That does not mean that they are an AI tool, that they are a human team. That's an extension. So in our last minute, what could you tell the audience here about the timeline for getting a virtual team established? If there are any needs, such as just staff turnover for the internal team, recruitment difficulties, or just the high cost of workforce at the moment?
Right. Yeah. So we're looking at, depending on the health center, what their needs are, what their data is showing, bringing on a virtual team could be as short as 30 to 60 days to have them up and running and assisting patients. But that back and forth communication and cooperation and partnership between Alcar and in the health center, I think is really what's going to determine how successful that is, and how quickly that that can be implemented for the health center.
All right. Well, thank you, Joe. We are at time. We'd like to thank everyone for joining. Joe, thank you as always for your wisdom and your experience and expertise in sharing that. Stay tuned for our upcoming webinar series to continue, and I appreciate everyone for joining. Thank you so much.
Thank you, everyone.
Bye-bye.